has made several strides. We've been in a position to make sure that we manage our population, making sure that we space the birth spacing, making sure that we provide the products required. And indeed, Kenyan government has been in the forefront, making sure that we provide we expand the options available for women, going all the way from the contraceptive choices, and we also that women that avail those products. As at now, of course, you all know very well that as at now, of course, you all know very well that as at now, of course, you all know very well, 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 of course, zero preventable maternal deaths, zero unmet need, and zero harmful practices, including gender-based violence, teenage pregnancies. As we do this, of course, it requires concerted efforts from all of us. This is not only a Ministry of Health affair, but as I talk here, we provide direction to make sure that what is it that we need to do? How is it that we are going to do? And I'm happy that different players and different partners are very keen and have been very instrumental in making sure that what Kenyans need, we pool resources and collaborate. I want to thank the partners. As I was saying here, I cannot mention all of them because they have been instrumental in their achievements as we endeavor to improve the quality of health in Kenya. We know in issues of resource mobilization, in issues of bringing your time and bringing your mind and bringing your thinking into the table has made us achieve what we have achieved as in Kenya. We've made several progresses, as have been said by my colleague, that currently our modern contraceptive is around 57. We have dramatically and sustainably reduced the unmet need from as high as 20% a few years ago to 14% as per the last 2022 KDHS report. Our target as a government is to make sure that by 2030, we should be less than 5%. By 2030, we should not be having women dying from preventable maternal deaths. So, as we do this, I applaud the county governments who are represented here today because they are the implementers. Us at the national level, we provide the policy, the guidelines, and the standards. County governments have been instrumental. And most of the counties, for your information, are making several strides because they have improved access. Several dispensaries have been built. Several maternal units have been built. And several workers, healthcare workers, have been employed. The roads have been improved. referrals have been improved. And all this equates to improving quality of care. As has been said by my colleague here, Dr. Wamalwa here, that the county governments have for some time improved on financing, on health. Of course, that goes into improving the quality of care. National family planning products have been a national strategic commodity security, and we've seen a lot of impact, outcomes coming out of that. Availing the family planning products has made a lot of changes and has actually improved on the quality of care. At the same time, therefore, I want to thank the development partners, FCDO, UNFPA, USAID, Bill and Melinda Gates Foundation, and others who have contributed in making sure, collaborating with the Ministry of Health for the provision of family planning products. On the same note, as we continue to making sure that we improve the quality of care for mothers and children, other issues therefore come in. The maternal mortality has stubbornly stagnated. We would therefore also need to refocus. How do we make sure? Because the stagnation in reduction of maternal mortality is on issues of quality of care, which I've mentioned. And most of them is mostly due to delays in referrals. At this juncture, I want to thank the partners because there is now a lot of negotiations and discussion on the implementation of the M-Mama project. This is collaboration between the Kenyan government, Safaricom, and Safaricom. One of the key killers of maternal mortality is delays in getting into emergency care. And right now, we hope by early next year, the M-Mama project will be implemented here in Kenya. An M-Mama project where it has, in other countries where it has been piloted, has shown that it will reduce maternal mortality significantly by a big proportion. So at the same time, as we do this, we would also want, we are still in discussions, how then do we get life-saving commodities for the women and children? Those are the discussions which are going on. So therefore, as we do all this, therefore, during these deliberations, right now, Minister of Health, we are privileged that with the bottom-up economic transformation agenda, UHC is one of the priorities. And UHC is being driven by none other than the President of the Republic of Kenya. As we do this, primary health care has been given a lot of emphasis. With the primary health care, with the community health promoters, I would like, therefore, also to take this time so that to ask, to challenge you, and to encourage you, and to ask you, how can we leverage on the community health promoters? We need to empower them. We need to strengthen them because they will be drivers. If one community health promoter is going to visit 100 families per month. And we want the community healthcare promoters to provide information. And I think that has been one of the challenges which we're having, that women, children, and even male don't have information on very many things. And I'll give you an example, that one of the causes of what is causing mothers to die before, during, and after delivery is hemorrhage. And one of the key interventions is making sure that that woman gets enough iron. That is, in fact, the latest research shows that one of the lead causes of postpartum hemorrhage is because of anemia. And anemia, it can be avoided. So as we do this, we look at also those interventions. What can we do to make sure that women get information on pregnancy dangers and the rest? At the same time, we have been having challenges of data. And good enough, with the launch of the community health promoters and with the provision of the smartphones, where we have the electronic community health information system, which is directly connected to DHIS, then we will get enough data for us to make proper decisions. All said and done, therefore, ladies and gentlemen, I therefore want to wish you fruitful deliberations during this conference, and at the same time, thank the conveners of this meeting, that is the PS Kenya, in the Desip project. We encourage similar projects because as we talk about 50 million people, I know PS Kenya, they're operating in few counties. We also want to call the other partners to leverage on this and help, and as we all try to improve our indicators. Thank you very much. Our fruitful deliberations. Asanteni sana, Mungu awabariki.
Thank you very much, Dr. Serem, for those great highlights. We really appreciate your presence and your attendance. Thank you very much. A round of applause to the panelists as we round up that session. Those who gave us opening remarks, thank you. Wow, the room is full, and it's so good to see so many familiar faces. I'd like to actually honor Josephine, who was the Desip project director when it started. I remember her taking me through what Desip was all about in 2019, and I almost spent the whole day in the office just listening to her. And who knew, 3 years down the line, I'd take it over from you. Thank you so much, Josephine, and you're welcome. Thank you. So we'll head over to the comms team, the communications team, and they'll play for us an overview of the Desip project video. So I'm directing all our attention to the screens.
Population Services Kenya is the leading social behavior change communication organization with 30 years experience of measurably improving the health of Kenyans and supporting the Ministry of Health in addressing public health priorities. The United Kingdom, through the Foreign Commonwealth and Development Office, is strengthening reproductive health in Kenya through the delivering equitable and sustainable increases in family planning under a program known as Desip. The Desip program has been implemented by a consortium of partners led by Population Services Kenya and implemented jointly with AMREF, Options Consulting Limited, Faith to Action Network, Health Rights International, Population Services International, and Voluntary Services Overseas. We are excited to invite you to the Desip Learning Conference to share best practices and lessons learned from implementing high-impact interventions.
My name is Akato Ekirapa, Health Team Leader at British High Commission, Nairobi. The UK has been very proud to be associated with the Desip Family Planning Programme, where we have invested £36 million over the past 5 years in enabling sustainable and equitable increases in family planning across Kenya. By having concerted investments with other investments in Kenya, we have been able to contribute towards reduction in total fertility rate, as well as also increasing modern contraceptive prevalence rate.
My name is Jacqueline Owigo, and I'm the Social Development Advisor at the British High Commission in Nairobi. The Desip program contributes to the UK's wider aspiration on women and girls in Kenya. The program addresses barriers facing men and women in accessing family planning, so be it low levels of awareness or addressing the bottlenecks in delivery. Through the program, we are empowering women and girls to be able to make a choice as to when and whether they would like to have their children.
Hello everyone, my name is Dr. Charlotte Pahe from Desip. I'm the Desip Project Director at PS Kenya, and it is my honor to welcome you all to the National Desip Family Planning Learning Conference. In this conference, we aim to do the following. One, to share with you some of the promising practices and some of the lessons that we have learned in the implementation of the Desip project since 2019. Desip is currently in its 5th year of implementation. Secondly, we hope to gain some commitment from various stakeholders and from the government, particularly through the Ministry of Health, to institutionalize some of the high impact interventions that we have had in the implementation of the project to ensure that these promising practices actually move to scale.
My name is Dr. James Rotich. I'm the RHFP specialist for the Desip program. And Desip has achieved a lot. And if I was to start with a few things, of course, some statistical level calculations for impact. You find that Desip has averted unintended pregnancies, approximately 1.3 million. The Desip has also averted maternal deaths, around 3,600. The Desip program has also averted unsafe abortions. That will be around 300,000. And the Desip program has achieved DALIs of around 2.1 million. Now, in terms of output, the program has also made some significant achievements. Since the beginning, in 2019, the program has achieved more than 2.8 million CYPs. Again, in terms of women of reproductive health who are adolescents, the program has consistently achieved more than 10%. In terms of number of FP users, the program has attained more than 2.7 million. And in terms of quality of care scores within the Desip facilities have actually been more than 80%. So this, in addition to many other achievements at output and activity level, are what the program has achieved. Thank you so much.
So I'll take you through this session. Next slide. So Desip is a UK aid-funded program, and as Dr. Margaret mentioned in her presentation, it stands for Delivering Equitable and Sustainable Increases in FP, with a focus in low modern contraceptive prevalence rate counties in Kenya, in line with Vision 2030. In our year 1 and 2 of implementation, Desip focused in 19 counties, and we were supporting public, private, and faith-based facilities. In our year 3, 4, and 5 that we are currently on, we are focused in 12 counties. Our target population is adolescent girls, poor women who are living on less than $1 a day, $0.9, and people living with disabilities. We are focused primarily across the counties that have the lowest MCPR rates, as well as in the ASOL counties. Next slide. I'm not sure whether they are visible to everybody on those screens. Okay. So these are results framework in line with the FP22 strategies and commitments. Output 1 is focused on increasing awareness and acceptance of family planning. As you go through today and tomorrow, you'll come across and engage with our teams from the counties that will be taking through the various interventions that are being implemented across this output, including engagement of religious leaders, including male champions and youth champions to be able to increase awareness and acceptance for FP. In terms of output, our second output, which is output 2, we aimed to improve availability of FP services. For output 3, we were improving the quality of the FP services. And output 4, we're increasing the capacity for the country and the counties to plan, finance, and to coordinate FP. So all of this was being done to achieve the greater outcome that there'll be more equitable access to FP services in Kenya, especially for women in rural areas, adolescents, and PWDs, who tend to have the most children, to be least educated and have the most children. With a goal to ensure that women and girls can safely plan their pregnancies and improve their sexual reproductive health rights. And the overall impact that we intended to do is to reduce maternal mortality, newborn and child mortality, and increase MCPR in Kenya. Next slide. So Desip is a consortium of different partners led by PS Kenya as the prime. Initially, up to year 4, we had several partners, including the following that were health service delivery partners. We had PS Kenya, we had Health Rights International who are with us, we had Faith to Action who are with us, we had AMREF Health Kenya, and across the health systems strengthening spectrum, we had Options Consultancy, Voluntary Services Overseas who were supporting social inclusion, and PSI who were supporting our learning agenda. All of these partners are actually present with us, and you'll be interacting with them as we go on with the conference. Next slide. So we started by undertaking inception meetings in all the 19 counties. We had letters of commitment signed and executed by the county executives. And then we took a service availability readiness assessment in all facilities, enabled to identify the gaps so that we would be strategic and we based context in what we were going to do. Next slide. So for output 1, what we've managed to do so far regarding increasing awareness and acceptance for FP, we've been able to undertake co-creation and insight meetings with different county focal persons, and we've come up with strategies and approaches. I'll be sharing some of them. We managed to develop and disseminate 19 social behavior change communication strategies. We are highlighting Marsabit County's strategy right there. We carried out demand creation for FP. We did support the counties in terms of developing, producing, and distributing FPIC materials, and we were capacity building demand creation agents, as well as meeting them in different times and points to support them in terms of building their capacity and making sure that the messaging that was being passed is actually accurate. We also supported community quality improvement meetings. So these are some of the SBCC strategies that were adopted after being supported by the Desip project. We have the one for Garissa County, each built to take into account the context in which it's implemented. We had the one for Lamu County, Marsabit County, and Mandera County. We took some unconventional messaging approaches where we did branding for different social places that people access, with the messaging around Desip, what Desip is all about, and what planning for FP meant for them and their communities. Next slide. So in terms of improving availability for FP services for our output 2, we undertook capacity building of healthcare providers. This was done through different modalities. We had some classroom trainings in particular structures. We also piloted the WhatsApp-based training, both for counseling for choice and for COVID-19. And for these particular ones, healthcare providers could actually access the entire modules for counseling for choice and COVID-19 on WhatsApp platforms. This particularly took place when the COVID pandemic hit, and it became impossible for people to meet physically. So that became the innovative approach that continued to ensure that capacity building was going on. And then we also layered on the on-site structured mentorship, which we'll be talking about in the sessions that are coming up, where it's a skills-based kind of a training for knowledge transfer among healthcare providers. This one moves away from the classroom and actually takes place at the facility. The project also did a post-training follow-up to make sure that skills that are being learned are actually being used at work. We partnered with UNFPA in terms of commodity security as well as the MOH to make sure that we were supporting the counties to ensure there's availability of commodities. This was done through social marketing of FP commodities on one arm, but on the other arm we were supporting commodity security meetings and redistributing commodities when we came across counties where there were issues in terms of stock. We also supported some of the meetings that were undertaking focusing on quantification. We had a social marketing approach that we'll be talking about as we go on, and we also procured and distributed several FP equipment that were placed in different sites. We'll go through a highlight of how some of them looked like. We also supported by printing and distribution of FP guidelines, some job aids. We had training manuals, including COVID-19 IC materials, just to help healthcare workers be able to feel confident in offering FP services. We did expand availability of FP through both outreaches and inreaches, particularly in marginalized geographies. And we undertook a model called community-based distribution, where we take a cadre of CHVs that are specially trained to be able to offer shorter-term methods of FP at community level, and thereby removing the barrier of access. In all service delivery points, we try to integrate FP services at all to increase access to FP. Next slide. So these are some of the items that the project procured. I won't go through the numbers, but in summary, we had autoclaves, we had forceps, we had different machines, pedal bins, and we have some of the photographs there with Josephine, who's thus receiving and supporting the facilities to be able to receive at the inception of the project. Next slide. So in terms of quality of FP, we supported the national program to disseminate and to train on the national FP standards for healthcare facilities. So we also supported to ensure that facilities actually embrace quality. And during COVID-19, we were undertaking different innovations to ensure that the training did not stop despite the challenges that were being experienced. We were undertaking assessments in facilities as well as integrated support supervision. For our network of private providers, we took them through and we instituted the Healthcare Network Quality Improvement System, commonly known as HANKIS. This is a mobile-based application that supports facilities to be assessed, monitored, and evaluated based on a digital platform in terms of the quality of services that they're offering. Next slide. So this is how the FP standard score looks like, just a breakdown, such that at the end of the score, a facility either scores 0 to 24%, which is a very high-risk facility, non-compliant, and ideally needs immediate action by a quality improvement team until it meets the standards for it to be able to offer FP services. We have a standard there of between 25 and 49%. This is a high-risk facility that is minimally compliant, and then based on the gaps that are have been identified, we implement QI activities and review them within 1 to 3 months to make sure that the FP services that are being offered are actually up to the staff. For facilities that score between 50 to 74% based on the standards, these are partially compliant facilities with imminent high risk. Areas of improvements are usually stated, and with a goal to make sure that the desired standard is met within 3 months. And then finally, we aimed to actually make sure most of our sites are between 75 to 100%, which are fully compliant and are meeting target, but these are the kind of facilities that continuously supervise for support and ensure that they meet the quality ratings. So all our facilities that were supported went through the FP standards and were supervised and assessed as such, and we undertook QI processes to make sure that we bring them up to speed. Next slide. So this is an example of a private sector quality assessment and what their results look like. how they were doing in terms of the different commodities over time and how they went improving. We can see them moving down here continuously from 79% to 80, all the way to 90. So, actually no, this is the other way around. Sorry, so but we can see the assessment over time in how they're doing, but with an overall goal in our minds to make sure that the facilities actually improve over time. I've just realized these are the different commodities. Apologies for that. Next slide. Great, and then finally around output 4, we intended to support the country to increase its capacity to plan, finance, and coordinate FP, and we did this through different approaches. One, we supported the development and review and launch of various RH policies. Some are highlighted on my left. We also participated in accountability forums, including national and subnational technical working groups. We supported commemoration of World Health Days, including World Contraceptive Day, with an aim to call to action and galvanize support from the global and local context regarding awareness to FP. We supported the costed implementation development plans to ensure that resources actually allocated for FP, and we're also taking part in the discussion that segments customers, looking at the market as a whole, to receive FP from private facilities, and then structure that context so that these ones being able to access FP from private can get them from there, and we are left with a lesser burden of those who need to access FP from public facilities. Next slide. So we had a landing agenda for the project, and this is across 4 particular themes. One, around safeguarding. This is focused on making sure that we are preventing sexual harassment, so that the people who are vulnerable are not finding themselves to be victims in that sense of sexual harassment, so that we are not only protecting communities from sexual harassment, but we're also protecting facilities, staff and the patients who go there from sexual harassment from other people in the community. We also have a social inclusion learning agenda where we train healthcare workers to be able to provide access for FP for people who are living with disabilities. We also have an agenda of demonstrating equity in reaching underserved populations, as we have highlighted, and we also will be sharing some of our thoughts around sustainability and our exit strategy. So these are some of the questions. We'll be interacting with them as we go on with the conference. Next slide. One of the unique things about the Desip project that I actually don't think I've seen this in any other project in Kenya is social inclusion. And this is just the awareness of leaving no one behind, making sure that as we plan and we do public health programming for the large masses of the population, we're not leaving behind some people with disabilities, vulnerable populations, for any reason. So we here have some work that we did at Ogande SCK dispensary in Homa Bay, just something as easy as setting up a ramp, which ensures that there's access for someone who's accessing the facility with a wheelchair. A similar structure that was done at Lei Mayan Hospital in Kajiado, making sure that the trench was filled and making it easy, because then once we sorted out the structural issues, it is easy for someone who's on a wheelchair to access services actually without needing the help of another person. Next slide. Great, so this is some of our samples. When you come across our facilities and our work, you'll see some of our safeguarding awareness material that we are protecting. The healthcare worker has been trained so that there isn't sexual harassment being perpetrated against the community members and those visiting the facilities, and that in our communities, our people are actually empowered to be able to speak up against sexual harassment and abuse. Next slide. Great, so in terms of our performance in numbers, year over year, actually I said 3 years earlier, it's actually 5 years. We're in the 5th year of implementation. Next slide. So year by year, we've been able to achieve all of our targets in terms of the CYPs, the couple layers of protection against the target. We managed to overachieve our target in year 1, achieving a target of 123%, 155% in year 2, 180% in year 3, and 117% in year 4. In year 5, as at October, we are at 69% of the target, and we look forward to actually surpassing this target by the end of this year 5. In terms of the number of family planning services provided, we were able to almost reach the targets year by year. In year one, we had some of delays in terms of setting up, starting off, so we were able to achieve 88% of number of FP services for that year. In year two, we were well above 90% at 96% of FP services offered against the target. In year three, again, we managed % of the target, although we had a target revision we had a bit of reduction in funding amidst the COVID and what it did to the economies. Year four, again, we managed to now reach 106% of our target, having really surpassed it. And in year five, we are on track to make sure that we surpass that target by the time we reach the end of the year. Again, looking at some of the uniqueness about the project, right now, as a country and in the Desip-supported counties, healthcare workers have been trained and are able to demonstrate and report data regarding PWDs who are accessing FP services. When we look at this data quarter by quarter, we see an improvement. Some quarters back, we had just about 20, 30 PWDs being reported across the counties, but with the support of Desip, we continue to see that not only is the service being offered, but we're actually demonstrating scale-up in terms of reporting these numbers, and these are actually available on the on KHIS as well. Next slide. So what are some of the challenges that we experienced? We were very excited when the project started in 2019, and then COVID hit a few months later. This environment became very unpredictable. It became very tricky to do things the way we were used to, so we had to innovate a lot. Some of the trainings that were meant to be done physically became digital trainings. That led to the innovation around the training on WhatsApp platforms for both C4C and COVID-19. But in a sense, some of the work was really slowed down, and we did support the counties with PPE, material, masks, sanitizers, and the rest to make sure that there was some amount of work that was still going on. We had a funding reduction midstream, and that meant a reduction in scope and a scale down in some of the activities, but we've been able to regroup, and we are able to actually maintain some of the work that we feel is core. In the northeastern region, insecurity can disrupt some of the activities that are planned, leading to delayed implementation. The team faces challenges with movement within the county, but we've managed to link with PLSO and other security agencies, but this can sometimes actually disrupt work plans in terms of achieving what needs to be done by when. The country is frequently facing commodity stockouts, which can hinder access, but we continue to sit within the teams that forecast and produce data for FP, and we also support the facilities to be able to actually report accurate data so that they may be able to get the FP commodities when they need them. Data quality continues to need strengthening among staff. We are particularly challenged when staff transition. Once you've trained them and they're up to par, and for whatever reason they have to move from one region to another, then the facility transitions really affect us in terms of training for data quality, but these continue to be some of the priorities that we are undertaking. Next slide. That's it. Great. I thought there was a lessons learned. Did I miss it? Great. So these are things that we have learned, and we'll be showcasing much more than this, that county ownership of activities and leadership is really key in terms of delivering FP services. The continuous stock verification, as well as accurate forecasting and quantification, make sure that FP commodities are available when needed, such that with all the outreaches that we've planned, if we don't have commodities, then the people in the community reach the facility and then there's nothing to actually have. So commodities continue to be really critical to ensure that FP services are available. On-site structured mentorship, which we'll be talking about in the sessions that are coming up, have proved better in terms of transferring skills because these are done at the facility and someone is able to over and over see how the mentor is undertaking insertion of an FP method, which makes the skills transfer much better than the classroom training, and we'll be having some panelists talk about that as the conference goes on. Male engagement, as outlined as one of the key strategies in the FP 2030 commitments for Kenya, continues to be very, very important and very strategic for increasing FP uptake. And of course, the use of a multi-sectoral approach such that we have representation across all sectors in terms of institutionalizing and promoting ownership and of social inclusion particularly. Thank you so much. I think that's the end of the overview of the project. It took us very fast to be able to save time so that we'll be able to then take apart the meat in the sessions that follow. Thank you very much.
Thank you so much, Dr. Pahepo, for that presentation. And what you have seen there, it was as a result of great commitment from Desip consortium partners with support from the Ministry of Health at both level, county and national level, and also with funding from UK Aid and through a very able leadership from the current Program Director, Dr. Pahe, and former Project Director, Josephine Biu. We appreciate. And for that, we can give all that team a round of applause. Thank you. Edwin? Yeah, I think a minute.
A minute. Okay, all right. So we've been seated for quite some time. I want us to stand and just stretch a bit as we get into the next session. So if you don't mind just being upstanding, thank you. Thank you for those who are standing. Thank you so much. You can clap for yourselves. Clap for yourselves. Thank you so much. Amazing, amazing. So as you stand, I want you to stretch. Just stretch and ensure you are a bother to your neighbor. Stretch until your neighbor is complaining. If they're not complaining, you're not stretching enough. Stretch until your neighbor is complaining. Stretch, Kabisa, stretch, stretch. Push them away, push them away. Tell them, give me space. Tell them, give me space. All right, amazing. So, as we stand like that, we are going to count with our fingers. So I hope everybody can see me. I know I am dark and I'm in black. But at least you can see something gray. Oh, perfect. So we'll count with our fingers. When I say 1, I want us to place our right hand index finger up. All right? When I say 2, I want you to take your left hand with the palm stretched out and place it on the you. All right? When I say 3, I want you to try grabbing the finger to your left and don't get caught on your right. Team, you can just continue to set up. Denise and Richie, just go on. As we count. So 1, everybody, this is 1. Everybody, this is 1. Then let's go to 2. Don't grab yet, don't grab yet, don't grab yet. You're just placing the palm on that finger. And 3. Again, let me repeat the instructions. When I say 1, we go to 1. When I say 2, your left hand on that finger of your neighbor. When I say 3, try grabbing the finger to your left and don't get caught on your right. Okay? Simple? We go that? Let's try. One more time, hands down, relax, relax. I told you to stretch, remember? So everybody, 1, 2, 3. So how many were caught? If you caught somebody, please lift their hands up. If you caught somebody, lift their hand up. I have like 30 seconds to go. So I will tell a story. And this story will have all those numbers. When you hear those numbers, do as required, all right? So when you hear 1, you raise that finger up. When you hear 2, place that hand on that finger. When you hear 3, grab that finger, all right? So let us try and see if you have A students in this conference today. Once upon a time, those who are sharp have known that once has 1. So once upon a time, right here in Nairobi, there lived 2 children. These 2 children were all amazing, lovely little boys, and they enjoyed playing at home with their brothers and sisters. Now, they had 3 brothers. All right. I hope you're enjoying the session as we continue. Let me invite MC Kamande back on stage. Thank you, MC.
Thank you so much, Edwin. Can we applaud Edwin for that? Yeah, and checking on people's faces, look like we need to replenish our energy levels. I would request that we break for a cup of tea for 20 minutes. Kindly 20 minutes. And in addition to a cup of tea, we have very nice poster presentations just outside. We also have booths which have information backing up what was presented by Dr. Pahe. So we will break for tea right now, and then we come back. It is 5 minutes to 11. I request that we be back at 20 minutes past 11. Thank you.
Desip program as a mainstreamed social inclusion in its programming. And what I mean by this is that social inclusion is part of implementation of our interventions, and the target, some of the target beneficiaries include the people with disabilities. We recognize the barriers that the people with disabilities experience when they are coming for reproductive health services. And thus the program intentionally wanted to address these barriers and ensure that these people are able to access these services, and thus enhancing equity in programming. World Sign Language Day is very important for a number of reasons. People have not focused on the socially excluded communities when we are delivering services of any kind, and more so the sexual reproductive health services. And therefore there is need to create awareness in terms of the barriers to access that these people experience, and even the negative attitudes that the healthcare workers have against these people. So it is important to create awareness on such a day and bring people to understanding, and even educate some of the healthcare workers for improved attitudes toward handling such people. When we started Desip program in 2019, the program having one of its target beneficiaries as people with disabilities, did an assessment to assess the situation in terms of how disability friendly were our facilities, our platforms, our decision-making organs in terms of health. And I think the program has made a lot of progress, because one of the interventions the program did was to undertake capacity building of training of healthcare workers on social inclusion, and this really has helped them to understand the situation of the socially excluded people, especially the people with disabilities. We've advocated for inclusion of the disabled or people with disabilities in some of the forums, like the technical working groups and other decision-making and accountability forums in the counties. We've been able also to produce a lot of materials. For example, we've produced brailles for people who are blind. We've developed sign language posters and materials, IEC materials, that is going to help in communication with these people. I think we want to acknowledge FCDO for the support they've given to Population Services Kenya, because through them we are able to support a group that was initially socially excluded. And through their support, we've worked with the networks for people with disabilities. Through their support also, we've interacted with these people. Through their support, we've had influence in the community. So we want to acknowledge them and thank them for what they've done and the support they've given to PS Kenya through the Desip program. Of course, in the 12 counties that we are in, we normally have meetings that we communicate what we do, involving the people with disabilities. We are also very active in the social media handles, and you could follow us. We post a lot of information on the support that we offer to the people with disabilities. So we hope to interact with you in our social media handles.
Population Services Kenya joined the rest of Kenya's healthcare providers, policymakers and stakeholders in Kapkatet, Kericho County for the 4-day Universal Health Coverage Exhibition and Conference hosted by the Ministry of Health. The Accelerate project is funded by the Danish Embassy and implemented by a consortium led by PS Kenya in partnership with the Gender-Based Violence and Recovery Center and Population Services International. We also have an adolescent project called Binti Shupavu. The Binti Shupavu project is funded by the Children's Investment Fund Foundation. The project aims to support partners who deliver high-quality, equitable and gender transformative programming at scale to transform and empower the lives of poor and vulnerable children and adolescents in developing countries. So this is in very rural areas. This project is funded by CIF and it's in 4 counties at the moment. We also have this samples bag that has different reproductive health commodities, condoms, injections. There's also different methods or ways of family planning. And this is a sample. This is what we use for training. So this is and it's used to illustrate at a facility or at wherever the training is actually happening. This is a simulation of an arm. So the healthcare workers who are being trained, this is for measuring to show them where to inject. The United Kingdom, through the Foreign Commonwealth and Development Office, is strengthening reproductive health in Kenya under the Desip program that delivers sustainable and equitable increases in family planning. This is overall what PS Kenya does across, and our most recent program funded by the US government, the Private Sector Engagement Program, that seeks to transform the healthcare market in this country through improving patient outcomes, choices, and there are big things that we are doing under that project that I'll show you once we get to that corner. This is HIV self-testing. We are funded by Children Investments Fund Foundation, CIF, to create awareness on the existence of different HIV self-testing kits. We have different kits in the market. We do not focus only on one product. Our role is to create a healthy market so that more people can know that it exists and also demand for it and ensure that you have quality products within the systems. In addition, we also have the OraQuick, the oral HIV self-testing kit. It's the only oral HIV self-testing kit in the market. So what we are working with the government and also other players is to see how we can be able to bring in cheaper commodities that are more accessible, more affordable, so that more Kenyans can be able to access. So this we work also, we collaborate internationally with Unitaid and other partners to support in creating access to more oral self-testing kits.
My name is Emily, and I'm the director of Amazing Group of persons living with disability, where we work under 4 thematic areas. We do governance, we do health, and we also do education and advocacy. I'm also a human, and I'm also one of the champions in the Kenya Network for Women with Disability. And when it comes to health, as one of our thematic areas, we worked with the PS Kenya and under the Desip project, where we have managed as an organization to bring more than 300 women and young girls with disability to good access to family planning. And we have also created the community awareness in the community through theater on access and good relationship with the providers, on good access to family planning and GBV issues. Through the Desip project, we managed to receive a lot of facilitation. Most of our access to the community at the community level, we managed to receive some of the IC materials, like the SLI booklets. We also received some IC materials, the family planning material booklets. When we are doing our community outreaches, it makes our work easier because at least we have a place to refer.
Through my knowledge in sign language, I can be able to reach all the deaf community by starting a small sign language in my work area. So my in charge and I decided that we choose a day, and that was on Wednesdays in the afternoon, and we started doing sign language every afternoon. And out of these classes, Desip was very happy and proud of us, and they supported us with the materials. And these materials were books. They supported us with around 30 to 40 sign language books and guidelines. And also, they also gave us posters and IC materials. This is information and education communication materials, so that you are able to reach the deaf community in the easiest manner.
So we always sensitize our persons with disability to visit the health services or health facilities, so that they're able to get the right information on issues of reproductive health. And together with Desip, we've been able to sensitize not just the persons with disabilities themselves, but also the health providers. Because once persons with disability go to these facilities, they have to be disability friendly. The services also have to be friendly. The information or the communication channels, they're also supposed to be friendly to persons with disabilities. For example, when we come to a facility and we don't have an interpreter, definitely our persons with disability won't be able to get the right services. When we come to a facility and there are no ramps or the accessibility has issues, then our persons with disability won't be able to get those services. In partnership with some of the facilities, we've been able to train a few health workers in sign language. And through Desip, we've been able to sensitize the health workers in issues of disability etiquettes, and also how we are able to bring in more people to access services through sensitization and awareness, through the use of the self-help groups. In each sub-county, we've been able to have groups. This is the groups of persons with disability who act as champions to assist other people access the services. Because for us, we believe that it is easier for information to be passed by one of our own rather than somebody else who comes in and tell us to join or to access a certain service. So we use persons with disabilities themselves as champions of issues of reproductive health on the ground.